Good evening, everybody. And at the outset, let me welcome you all to the series of lectures uh, jointly organized by the Pulse Nutritional Institute in collaboration with the Indian Society of Parental and Enteral Nutrition. And to have this initial talk on this series, I have with me somebody who inspired actually me. My own interest in nutrition came, after I finished my fellowship and then started working at care with Dr. Ravinder Reddy. That's when my interest in critical nutrition, I started taking nutrition and the importance of nutrition. In fact, I remember the initial days where Dr. Reddy would come and would tell us, this is not the way you feed, this is how you feed, and then you're like, sir, leave it. That's not something which we need to bother about. Let us look at the hemodynamics. Let us look at the respiratory parameters. But over a period of time, I realized that as much as taking care of the hemodynamics, nutrition, or the renal organ support is important. Once the patient comes out of the initial crisis, there are very, very few interventions which actually have a profound impact on not only on the survival, but the quality of life that the patient is going to live after he gets discharged. And that is where nutrition plays a very, very key role. And to have this initial talk on this series, I invite Dr. Ravinder Reddy, who is a consultant surgical gastroenterologist and a GI surgeon, and who has been the president of ISPEN and one of the key brains behind the upcoming PENSA. Sir, over to you.
Good evening, ladies and gentlemen. At the outset, I'd like to thank Pulse Nutrition Institute for enabling what is apparently one of the first of the many, many such nutritional events which you are going to do that. Basically, this is organized under the aegis of the Indian Society of Parental and Enteral Nutrition. And the aim is to have a lecture or two every month from the various key opinion leaders and various dietitians from across the country. And this being the inaugural one, that's why it explains why I'm actually being the speaker. Otherwise, I'd like to hear and learn from all the other luminaries who belong to the Indian nutrition field and the professionals from the nutrition faculty of our wonderful country. Now, I was asked this topic was actually suggested by Dr. Ganshyam, saying that even though I put the title there as nutrition support in the critically ill, he actually wanted me to emphasize on what exactly happens as far as metabolism is concerned in the ICU. Now, we all know that there are many, many publications to know that one side of the coin of treating a patient who is acutely ill is actually the source, is the organ dysfunction, is there interventions for organ dysfunction, either in the form of ventilation or vasopressors or inotropes, fluid resuscitation, putting in tubes from the nose into the urethra, into the lungs, into the heart, and monitoring in many, many ways. That is one side of the coin. The other side of the coin is actually nutrition, because without nutrition, there is no way we can actually we can actually get over the initial insult. What reminds me is some of you all in the Eastern Europe right now, there's a raging war that's going on, and you all have seen the huge trucks and huge tanks of one country, which are totally came and jam-packed because it was so soggy, because the other nation actually let their open their rivers and barrages so that these things get stuck. That is exactly what happens in critically ill patients, right? Where even if we have huge trucks, even if we have huge tanks, we'll still get stuck because in the mucky soil of the intensive care unit. With this preamble, let me talk about why we need for nutrition support. And I thought the best way to talk about is metabolism in normal. To know what is abnormal or to know what is bad, we need to know what is good, or the other way around. to know what is good, we need to know what is bad, right? So let me start with metabolism in the normal individuals and then go on to what happens in the patients who are acutely ill. And briefly, I'll touch upon interventions in the ICU patients because that's a topic for another day. But to complete the list, I'll just very, very briefly talk about that. So talking about the metabolism in the normal, right? This is a normal Indian diet. As you can see, we have the snacks, we have the Indian fried foods, we have the Indian chicken, we have some rice, and then we have some eggs. So it's a mixed meal, which is basically composed of humongous amounts of carbohydrates, a bit of proteins, and again, quite a bit of more fats than proteins. That is a typical Indian diet as such. And some amount of perhaps the prebiotics and probiotics at this point of time. And because we eat and all of it is actually assimilated, it is digested, it is absorbed and metabolized in the gastrointestinal tract, or that's where the first actual issue. So once we start eating, even though the brain actually, the first phase, the cephalic phase as it's called, we start secreting the saliva, we start secreting our gastric acid in preparation of the meal that's coming in. The actual part of the digestion in normal individuals occurs in the mouth. The moment we start eating and salivary amylase, it starts acting on the 1:6 links of carbohydrates and it breaks down the initial ones. And then there are a lot of other glycoproteins in the saliva that makes it into a nice big bolus so that it easily goes through the esophagus and enters the stomach. Now, stomach is a very hostile area as far as bugs are concerned because of the huge amount of hydrochloric acid. The pH is about 1.2 to 1.5. At the it's less than 2. So it kills most of the bugs in the food, because the food, however delicious as this might look here, it actually is actually not sterile, and it is sterilized by the hydrochloric acid in the stomach. Also, at the same time, there is some elements of fats are actually broken down to a certain extent by an enzyme called gastric lipase. But what happens most is actually the hydrochloric acid, which is so very important to break down the proteins, initial proteins. Remember, proteins are huge structures, right, as opposed to peptides, and it's broken down. And also the folic acid and other vitamins which are present in this food, and also at the same time the calcium, iron, magnesium, all the trivalent ions actually need the gastric acid to be broken down and to be absorbed, right? So the initial part of the stomach, the initial part of the digestion actually starts to a very significant extent in the stomach, and because of its peristaltic actions, it actually churns it to about less than 1.5 to 2 millimeters. Whatever food we eat, this is huge, 5 to 6 centimeters, but this is broken down in the stomach to less than 2 millimeters. And then it enters through this pylorus, as you can see. And because pylorus is a very narrow cavity, it just opens up and allows, there's only a squirt, it squirts, and then it enters into the duodenum. In duodenum, we have various cells. We have the cholecystokinin that actually acts on the, it is secreted by the duodenal mucosa. When immediately it goes and contracts the gallbladder, and it also acts on the secretin of the pancreas. It increases humongous amount of both the pancreatic juices and the biliary secretions in the second part of the duodenum, and then starts the major part, the second major part of the digestion. At the same time, even the carbohydrates actually are broken down, and the digestion starts. And then we enter the jejunum. In fact, the duodenum is not a very long structure. In fact, the meaning of duodenum is actually 10 fingers breadth. That's how it is. My duodenum is as long as my 10 fingers. So each of your duodenum is about 10 fingers breadth. And quite a significant amount is actually absorbed in the jejunum. And that's what it means. Jejunos means empty. A significant part, again, of the absorption occurs. And they are on the surface, in addition to these enzymes, on the surface, there are various enteropeptidases that actually help in digestion. So most of the macronutrients, the carbohydrates, proteins, and fats, they continue to get digested in the jejunum. Jejunum is a very, very busy organ, actually. It's quite thicker than ileum. and the absorption starts occurring at there. The sodium, we need insulin for the absorption of both the sodium as well as the glucose, except unless you are giving the patient, let's say, MCTs, that does not need any of these organs. Now, one of the major enzymes that actually secreted from the pancreas is the pancreatic lipase. And the fats which we eat are huge amounts, nearly about 18 to 20 to 16 carbon molecules, so huge molecules, and they're broken down by these. So basically what happens is, fat is a huge structure. Let me give an example by the span. Fat is as long as the span. It is broken down to very small pieces. It is absorbed. It goes to the liver, or it goes, and then it reforms to its original one, right? So that's what happens. And because it's a huge structure, it cannot be absorbed by the intestines, and that's why it gets absorbed by the lymphatics, unless we give the medium chain, we put less than 12 carbon atoms, medium chain triglycerides and MCTs, as we call, they're directly absorbed into the lacteals. And then comes the ileum. The total amount of all the secretions and the enzymes, we call it succus entericus, is about 6 liters. 6 liters. And a significant, and a lot of, again, digestion continues in the ileum. Ileum means most of it is in the flanks. That's what ileum means. Ileos means flanks. And most of it, and by the time those 6 liters, it comes down to the ileocecal junction, it's about 1500 ml, 1.5 liters of this chyme, right? Most of it is fluid, in a fluid state. It's not yet the solid phase as we pass in the species. It's about 1.5 liters, 1500 ml passes through the ileocecal junction daily, right? And then the right colon and the mid colon, and also the left colon, these are huge factories of fermentation. Remember, they have very precarious blood supply, so the oxygenation is not very good, right? And it's full of bacteria. The amount of bugs in the large intestine are 1 gram of the content of large intestine has about 10 to the power of 12 to 10 to the power of 14 per gram. That is 1 followed by 12 zeros, or 1 followed by 14 zeros per gram of constituents. That's a huge amount. Most of these bugs are our friends. We are alive. I'm talking to you. You're listening to me. We are getting up and walking. We are digesting everything. We are alive, mainly because of these bugs. And we need to feed those bugs by actually taking good amounts of fiber. And the reason why we need to take good amounts of fiber is we have to feed. We have to feed these bugs or the good bacteria. Those that act as food for this bacteria are called the prebiotics. And the good bacteria, such as lactobacillus or bifidobacterium, they are the probiotics, right? Together, they act, for example, the bacteria take up a lot of fiber. As you can see, some of it is fiber. It breaks them down into very small carbon chains of fatty acids, 2 to 4. They are called short chain fatty acids. Now, these are called postbiotics. We already seen what are prebiotics, prebiotics, probiotics. The bacteria that secrete the good substances which are beneficial for us are postbiotics, such as short chain fatty acids, which is anti-inflammatory, anti-malignant, and antioxidant. And it's such a small molecule that it percolates very easily into the systemic circulation, goes all over the body and imparts. And by the time it comes to the left colon, most of the water, including sodium, is reabsorbed by the large intestine. The large intestine has no digestive capacity. It has only 2 functions. Number 1 is fermentation. It's a huge fermentation factory. Number 2, it is an absorptive area. This is what, and we pass about 150 ml of water, not in liquid form, but in a solid form. We pass about 250 to 300 grams on an average of soft stools, and that contains about 150 ml of water, right? So that is what happens. That is a normal metabolism, right? And once it is metabolized, what happens is this huge amounts of macronutrients are converted into glucose, fatty acids, and amino acids, right? Now, these by themselves do not give the calories, so ATPs, energies, right? We all know that 1 gram of glucose gives 4, fatty acids gives about 9, because it has more number of hydrogen and carbon atoms, and again, proteins give about 4 kilocals. But how does it do that? It enters that's where it goes, it is transported into the liver, etc. And mainly the liver is one of the biggest source of mitochondria, right? The largest amount of mitochondria are present in our brain. The next one is actually in the liver. The third one actually is in the muscles, the mitochondria. They are different. They are in the evolution about 3 or 4 or 5 billion years ago. They actually came and said hello, hi, and we evolved, co-evolved. The multicellular organisms co-evolved. So they are bacteria, they have their own set of genes. The reason I'm going into mitochondria is mitochondrial dysfunction is a very significant factor which we need to be mindful of when we are looking at the patient who is acutely ill. More about it later. So the basic metabolic pathways of these glucose fatty acids is actually through glycolysis to the TCA, that is tricarboxylic acid. And one of the most important steps is actually the OXPHOS, or the oxidative phosphorylation, the PPP, the pentose phosphate pathway, the fatty acid oxidation, fatty acid synthesis, and the amino acid pathway. I have no intention to actually take a biochemistry class for all of y'all, but I'll just give you an overview of these things. Basically, glycolysis means this occurs in the doesn't occur in the mitochondria, it occurs in the cytoplasm. The glucose is broken down, that is glycolysis, that is glucose is converted to pyruvate. It can happen in presence of oxygen, it can happen in the absence of oxygen. So in presence of oxygen, we get 2 ATPs and 2 NADH plus and H plus. That gives about 7 ATPs. So aerobic glycolysis gives about 7 ATPs. So you don't need to remember any of this. You need to remember that in presence of oxygen, we get more energy. Whereas because it also occurs in an anaerobic way, in the absence of oxygen, it gives only about 2 ATPs as opposed to 4 ATPs, 7 ATPs with oxygen. Now, in cancer, what happens is, even if the patient has got good perfusion, the metabolism of carbohydrate is converted to anaerobic glycolysis. The reason this occurs is, even though it's a very costly way to go from point A to point B, that is only it's giving 2 ATPs, the byproducts of this are very, very essential to actually form various other molecules. That's the reason why in cancer, the metabolism is anaerobic glycolysis, even in presence of oxygen. So we need to be mindful of that when we are treating a patient who's got cancer. So that's what I was saying. The non-ATP benefits, especially in cancer, they are precursors for various biosynthetic molecules. Like they are precursors for the tricarboxylic acid, the pentose phosphate pathways, the gluconeogenesis, and the synthesis of lipids and amino acids. Now, then comes the citric acid cycle or the tricarboxylic acid. Forget about what's all is happening here. Just remember that this happens within the mitochondria. And it gives about 10 ATPs. This gives about 10 ATPs. One cycle gives it about 10 ATPs. It actually starts with oxaloacetic acid, and then coenzyme is a common denominator of carbohydrates, fats, and amino acids. It's converted to acetyl coenzyme. So this combines with that and it gets converted to citrate, and so on the cycle goes. The reason it's a cycle is because it goes and another acetyl coenzyme molecule goes in. So again, the non-ATP benefits are precursors of various biosynthetic pathways, gluconeogenesis, amino acid synthesis of various lipids. So the main role is actually to produce what is called as a reducing equivalence. That is the flavin adenine dinucleotide, that is FADH, and the nicotinamide adenine dinucleotide, that is NADH and H+. They are the ones that undergo oxidative phosphorylation. The most important step is OXPHOS, or the oxidative phosphorylation. It's also called as a electron transport system. That's where we actually make the ATPs. It produces plenty of ATPs, 36 ATPs per molecule of glucose. I'm not talking about the calories, that is 4 calories. This is ATPs. So this is the mitochondria. So these reducing equivalents, actually, there are 4 stages: stage 1, stage 2, stage 3, 4. Each stage, it actually increases the hydrogen plus in the inner and outer membrane. And that finally what happens is the amount of H plus is so much that it comes out and it revolves around and it produces the ATPs. I'm just making it very, very simplified. So the movement of this electron is actually what generates the ATPs. Suffice to know that we need our mitochondria or the original bacteria to be spick and span in a functioning order to actually make ATPs, because every patient who is critically ill is very severely, he needs these ATPs a lot. Now, coming to PPPs, basically it's an anabolic pathway, helps in proliferation and survival. I'll just stick on, I'll just go to others, because fatty acid oxidation, this is breakdown of the fatty acids, is one of the most important things. The reason is the long chain fatty acids and the medium chain fatty acids are quite big. They cannot enter the mitochondria. There are two layers in mitochondria, as I've told you. So it needs a molecule called carnitine. It is the carnitine that actually, some of you would have heard of carnitine shuttle, and it's carnitine that pushes them into the mitochondria and it undergoes beta oxidation. Now, there's another oxidation called alpha oxidation. Basically, it's a limited kind of oxidation, whereas beta oxidation, it goes on and on and on till the entire molecule actually is used up. In other words, one who undergoes beta oxidation gives more ATPs. I'll just give you an example here. So beta oxidation repeats many, many times till the entire fatty acid is totally used up, right? The number of rounds actually depends on the number of carbon atoms. For example, icosapentaenoic acid is about 20 carbon atoms. Docosahexaenoic acid is 22 carbon atoms. So each of them goes in 22 times, right? So each round of beta oxidation gives 14 ATPs. So you can imagine, on an average, we get for beta oxidation, we get huge amount of ATPs. That's more than 100, right? Now, this happens in normal individuals. This does not happen in critically ill patients. Only if we had this kind of beta oxidation in critically ill patients, then we would have won the battle in most of the cases, but then it doesn't happen. Now, we know that most of our diet is through carbohydrates, and carbohydrates has very limited stores in the body in the form of glycogen. It has less than 150 or at the most 250 or 300 in the liver. Sorry, not even 250, 100 or 150. 300 is about in the muscles, but that is not available for general circulation because it does not contain the enzymes to get converted. So the excess carbohydrates are converted to fatty acid synthesis, right? So plus fatty acid synthesis can occur on its own without the help of carbohydrates from acetyl coenzyme A, right? It occurs in the fat cells, livers, kidneys, including the mammary glands. Now, coming to the amino acid pathways, many individual amino acids are all essential for immune responses. We all know that, such as glutamine, arginine, almost each and every of the 20 essential amino acids has an important part. A key driver of amino acid metabolism is the mTOR pathway, right? It was called as a mammalian target of rapamycin, but now the M is changed to mechanistic target of rapamycin. Basically, it's an organ that is very, very essential for protein synthesis, or a system without mTOR pathways will not be making protein synthesis. And it senses the nutrition, energy intake, and especially the oxidative stress, which is huge in patients who are critically ill. And that's why we need the mTOR pathway to be proper. And it is regulated by insulin, by growth factors, amino acids, especially leucine, right? We need about 2-3 grams of leucine to make 1 gram of HMB. HMB is the main driver. Hydroxymethyl butyrate, right, as I've just written here, is the main driver that actually pushes the mTOR pathway. We need about 3 grams, to make 1 gram of HMB, right? It's a huge one. An average Indian diet doesn't even give 0.5 grams of leucine. So you can imagine, in our patient who is critically ill, we need to be mindful of this particular fact. So amino acids, they are important for growth factors. They are rich sources for energy levels and stress signals. Remember, we do not have stores of amino acids in the body. Each and every molecule of amino acid is involved in a function or the other. We do not have any stores. So all of this occurs in the mitochondria. So the glucose gets converted by aerobic glycolysis to pyruvate, gives energy. The byproducts act on TCA, and also the fatty acids, glutamine, and other amino acids actually act on the citric acid cycle. That enters into the oxidative phosphorylation. It gives huge amount of energy, 37 ATPs. The output of the biosynthetic pathways help in synthesis of nucleotides, proteins, lipids, so also from the fatty acid synthesis. So glycolysis gives ATPs and helps in biosynthesis. Oxidative phosphorylation helps in cellular longevity. Very, very important. So that is what happens in patients who, in you and me, in other words, in normal individuals. Now let's see what happens in patients who are in the ICU. Now, any patient who's admitted to the ICU, right, initially he has a bit of vasoconstriction, and because of vasoconstriction due to the various catecholamines, right, especially adrenaline, noradrenaline, steroids, right, there's vasoconstriction, so there's hypoperfusion. So what happens to the metabolism here is that it reduces. And ebb phase means is actually a frozen phase, right? And the main metabolic pathway during this ebb phase is actually, remember, I said we have glycogen store, we have glucose stores in the form of glycogen. So the main source of energy in every patient who's in ebb phase is actually only glycogenolysis. That's all. And then in the old terminology is the flow phase. We actually call it as the ISPEN calls it as, I think in 2014 or 2016, they changed it to late phase of acute illness. This is called as the initial phase of acute illness, the ebb phase, and the flow phase is called as the late phase of acute illness. Now, the main system that occurs here, the main process that occurs here is breakdown of proteins. Because in the ebb phase, the very limited amount of carbohydrates in the form of glycogen are utilized. There are no more stores. And remember, I've already told you all that there are no stores of any other amino acids in the body. And where are the amino acids present? They are present in the muscles. They are present doing various functions. And because of the ebb phase, initially, even the insulin increases. And what insulin does is, insulin, we all know, is an anabolic hormone, right? So even though fats with beta oxidation can give nearly 100 ATPs, it cannot be broken down because of high levels of insulin. Because the insulin resistance, the serum insulin level is so high that it prevents the breakdown of fatty acids to glycerol and triglycerides, right? That is why fats are not available as a source of energy. If we didn't have this particular pathway, then we would have had many, many good positive outcomes, but then that's how we had to live with it. So in flow phase, what happens is the protein is broken down. That's why it's called as a catabolic phase. The glutamine, the other amino acids, and some elements of like even the lactate or even the some small parts of the breakdown of the fats that actually acts as precursors for neoglucogenesis. So in flow phase, the main metabolic pathway that occurs is the gluconeogenesis, glucose from other areas other than the stored glycogen. That's what happens. And where does it come from? From muscle breakdown. That's why it's also called as a catabolic phase. Majority of the patients actually go into recovery phase, but there are a few significant ones in whom the initial cause of critically ill patients are new onset infection, new onset organ dysfunction, organ failure will push them into prolonged or chronic critical illness. Right. So this is what happens. This is the basic physiology of these patients. So any trauma, sepsis, illness, the immune cells, the neutrophils and the macrophages are activated, and they themselves increase the interleukin-1, 6 tumor necrosis factor, and also at the same time, the neuroendocrine processes have just sent all the catecholamines, which are secreted by the posterior pituitary. They act on the suprarenal gland. They secrete the cortisol, increase the glucagon from the pancreas and the other catecholamines. Basically, these are the ones that actually increase in the flow phase or the second phase. Now, ebb phase lasts for about 1 to 2 days. From second day onwards is the flow phase, right? And they act on the muscles and they provide the amino acids for gluconeogenesis. And that's why the patient actually loses significant amount of muscles. This is one of the basic denominator in every patient who's in ICU, be it due to COVID, be it due to dengue fever, be it due to cerebral malaria, be it due to major polytrauma, be it due to any other illnesses, right? That's what happens. In addition, the interleukin-1, 6, and tumor necrosis factor, especially alpha, directly, instead of going through roundabout subcutaneous route, directly act on the muscle and cause muscle loss. So it results in breakdown of the glucose, that is glycolysis, breakdown of fats to some extent, but most often it is actually the protein breakdown. Now, glycolysis gives lactate, as I've just said, in the absence of oxygen, right? Lipolysis gives glycerol. Initially, in presence, at least in the first phase, first 1 or 2 days, there's some element of triglycerides that are broken down to glycerol and, fatty acids are broken down to glycerol and triglycerides. And these glycerols, as well as amino acids, especially glutamine and alanine, they actually act as substrates for gluconeogenesis that increases the glucose. And they are the main source for all the immune cells and for the healing cells. At the same time, there is insulin resistance, and that's why there is hyperglycemia, so that increased glucose is actually given to the RBCs. These are all, they do not need insulin. Directly, they gobble up the glucose from the blood. The body generates about 50 to 75% of glucose requirements, especially in the early phase, due to various pathways. And this is one of the most significant, very, very damaging pathway is the protein breakdown. So in normal metabolism, we have amino acids, we have glucose, we have lipids in various utilization. We do not use amino acids, but we also use lipids, we also use glucose. But if you look at the patient who is acutely ill, the only source is not glucose or lipids, but the only source is actually the amino acids for tissue function and repair, organ function and organ structure and function, significant immune responses, skin integrity, neural functions. And that's the reason why the patient will have significant amount of protein breakdown. So this is the initial ebb phase, and that is the flow phase, is also called as the late phase of acute illness, and then goes on to the recovery phase and comes back to the normal metabolism. But whereas in some individuals, especially in acute prolonged illness, so they go into what is called as a chronic phase, where there are recurrent bouts of pro-inflammatory stimuli. And here, so also, there is a fluctuating metabolic demand. On day 4, the patient may need just about 18 kilocalories per kilogram body weight. By couple of days down the line, the patient may need nearly 25 kilocalories. So it's a very, very fluctuating demand. Again, this is the same summary of what I've just told you by the lipolysis, by the proteolysis, by the breakdown of the lactate. The denominator here is actually the loss of nitrogen. In other words, there is a patient has a negative nitrogen balance, which is very well depicted in this particular slide. This is the normal range of nitrogen balance. In selective surgery, it's not much, but in severe surgery and bone trauma, and especially burns, more than 60% burns, right? The patient will have a negative nitrogen balance of nearly 20 to 28 grams per day. That is huge. And when does this occur? Within the first 5 to 7 days. So if at all we are going to intervene nutrition for our ICU patients, this is the window period. And that's why the ICU definition of nutrition interventions by the ISPEN guidelines, I think it came out in 2019, they said that any patient or every patient who's in the ICU for more than 48 hours is at risk and will develop malnutrition if you do not intervene nutritionally. So nutrition is mandatory part of the care of patients who are in the ICU. So that's what happens in the ICU patients. Now coming to the intervention, evidence-based guidelines, this is one of the papers published in the Journal of American Medical Directors Association. Basically, you look at decreased food intake, weight loss. Is there a malnutrition risk? Because our patients are in the ICU. The answer is yes. We can use any kind of assessment. The simplest one is SGA, but if you have all the others, you can use any one. And then you come to the nutrition goals, route, timings, and then select a formula appropriately. How much to give? Initially in the ebb phase or acute phase, we give low. We give about uh, less than about, let's say about 15 kilocalories per day. This lasts for about 2 to 3 days. But if the patient is malnourished, then we start around 20 kilocalories. But by day 3 onwards or day 4 onwards, we increase the calories to gradually to 25 kilocalories and progressively increase. At the same time, we have to be mindful that, especially proteins, if the patient is admitted here, we do not underfeed as far as proteins are concerned. Right from day 1, we need to increase at least about 1 gram or 0.8 grams of proteins per day and gradually increase. It progressively increase by day 4 to at least 1.5 grams of proteins per day. Quite a simple one. This is by Paul Wishmeyer. Initially, he'll be one of our speakers in the forthcoming PENSA Congress I'll talk about in the end of my slide. The best way is enteral nutrition, which is more physiological, also acts on the gut-brain axis, maintains the gut integrity, has an anti-inflammatory effect. So, but then there are huge challenges. Important ones is, should we give the patient kitchen-based feeds or medical-grade feeds? This is again one of our studies where I was a PI, published in 2015 in the Journal of Human Nutrition. We actually randomized about 212 patients in each group. Half of them received only the dietary advice, the other half received oral nutrition supplements for 12 weeks. And what we found was those who were on oral nutrition supplements, they had a wonderful body increase in the body weight, increase in the body mass index, and increase in the daily intake of energy. So we need to give enteral nutrition and based on these strategies, because we know that patients who are in the ICU has gastric outlet dysfunction or delayed gastric emptying, so we have intestinal dysfunction, or ileus, prolonged ileus, so we need to have various strategies. Again, this is one of our papers, how to improve the strategy. Even though it is perioperative, I have one more paper actually in COVID published in 2020 in the Journal of Singapore, Journal of, I'm not sure whether it's there. So we start at 12 to 20, within 12 to 24 hours, we start at 15 ml per hour and increase it every 12 hours or so. We have to be mindful of the hemodynamics. If the patient is on multiple inotropes and progressively increasing inotropes, we should not be feeding them. But if the patient is on stable inotropes and the MAP, mean arterial pressure, is more than 50, you can tell your intensivist that, hey, we can start minimal enteral feeds to this part, to these patients. But we need to monitor the tolerance, adequacy, and other metabolic parameters. So, but some patients do need parenteral nutrition because at least 3 out of 10 or 4 out of 10 patients, EN may not be inadequate, or EN could be contraindicated, or their needs are such that we need to give the patient peripheral or central or supplemental or total parenteral nutrition, right? Whether to give soya-based parenteral nutrition or olive oil-based nutrition or fish oil-based or a combination of everything is actually a topic for another time, another lecture. It's a huge lecture. But the thing is, in acutely ill patients, it's better to avoid pure soya-based products and stick on to the other ones. A slide on micronutrients. Right from day 1, we should start the patient intravenous micronutrients. Whilst increasing the enteral feeds, it takes a good 4 to 5 days to achieve full enteral feeds on a standard ICU patient. So at least we need to give intravenous or parenteral micronutrients for at least 4 to 5 days. You can give any of them, but if the patient is malnourished, then it's always better to give 100 to 200 milligrams of thiamine, that is B1. This is one of the most important things to actually involved in the metabolism of carbohydrates, and it's one of the most important ways to avoid refeeding syndrome, especially if the patient is malnourished. Proteins, can't emphasize more. The most important is not the calories in the initial phase, it is the proteins. The most important thing in the middle of the critical illness, again, is not calories, but proteins. The most important thing, or more important thing than calories in recovery phase, is again proteins. So progressively we increase from 1 to 1.2 to 1.5 to even 2 kilograms. We have to be careful when the patient is on CKD patient. right? We have to be careful of that. These are the recommendations published in 2014. If the patient is CKD without on dialysis, then we have to be mindful. But if the patient is on dialysis, ladies and gentlemen, please do give at least 1.5 to 2 grams of protein per day, right? A word about this arginine, glutamine, omega-3 fatty acids is again by Rosenthal. These are the various ones. Most of the patients have systemic inflammatory response syndrome, and they go on to rapid recovery. Some of them go into persistent inflammation, that is PICS, and some of them go into compensatory anti-inflammatory response syndrome, but then they recover back to rapid recovery. At least 1 out of 3 of these patients go on to protein catabolism, cachexia, and finally we lose these patients because of progressive immunosuppression. Now, in various stages, especially as soon as the patient comes, it's better because the patient is pro-inflammatory. It's better to give the patient omega-3 fatty acids intravenously if the patient cannot tolerate oral or orally, because if you give orally, it takes 3 days. Intravenous, it takes about 3 hours to act. If the glutamine, especially if the patient is not in liver failure or renal failure, or if you happen to know the serum glutamine levels. And arginine, normally it is not used. Now, Dr. Ganshyam will look down upon me if I say use arginine, because arginine causes more hypotension. But there is a role of arginine, especially in few patients, especially after day 14, third week, the patient is still languishing in the ICU. Then there's a role, because that's where the CD4 cells, right, the CD8 cells increase, and the fuel for them is actually arginine. So arginine is important in the late phase, especially in patients who are in the long stage of their acute chronic illness. So to summarize, can the patient eat? If the patient can eat, normal food. If the patient can have some, then SIP feeds, liquid feeds. If the patient cannot, but can the gut be used, then use enteral feeds. As it happens, most of our patients cannot use the gut, right? So we have to go to parenteral nutrition. Or if the patient cannot, then you give the patient at least for 3 to 5 days IV fluids and then go on to parenteral nutrition. Within 3 to 5 days, if the patient is actually getting over it, then you just give the patient maintenance IV fluids. Ladies and gentlemen, I finished my lecture, but then I'd like to again thank the Pulse Nutrition Company for enabling me to share my thoughts on nutrition in critically ill patients. And it's a tremendous pleasure to actually introduce again Dr. Ganshyam, who is the organizing secretary of our forthcoming Parenteral Enteral Nutrition Society of Asia annual conference that is happening on the 1st, 2nd, 3rd of December in HICC in Hyderabad. And Dr. Ravinder Reddy, who's the chief dietitian from AIG, and Ganshyam, who's the director at Medicover of Intensive Care Unit. He's the organizing secretary, and Dr. Radha is actually chairing the entire session. So I'd like to invite each and every one of you all to actually take part in this amazing event. And it's going to be an academic feat. It's going to be an in-person conference, and we are getting 50% of the speakers will be luminaries, key opinion leaders from India and other parts of Asia. And the other few ones will be from Europe and from Australia, from Japan, and from Europe as well. So I'd like to invite you all, and thank you all once again for listening to me. Thank you all very much.
Thank you, sir. As always, your love and emphasis on the basics of nutrition always kind of mesmerizes me. It looks very simple. I mean, when we actually look at the way we feed people, we just look at whether we are giving feed or not. But the kind of complex processes that are involved in the entire aspect of nutrition, breaking down to the basic molecules and how they influence outcomes. Well, it's really an enigma, and it's always interesting to know that. Again, there is one question, sir. I mean, you kind of partly answered that. Again, one of your favorite topics, that is the role of immunonutrients in critical care by Dr. Manjari. Would you want to add a little bit more in detail to what you said?
Yeah, it's if you can get the serum level. I mean, any nutrient is actually is an immunonutrient. The definition of an immune nutrient is any nutrition or any macronutrient or its product that actually helps in processing the immune function or the immune response is an immunonutrition. Even zinc is an immunonutrition for that matter. Even iron is an immunonutrition for that matter. But the commonly perceived immunonutrients are actually glutamine, omega-3 fatty acids, and arginine. If the patient is undergoing an elective surgery or upper GI cancer, right, esophagus, oral cavity, pharynx, stomach, or even pancreas, or the patient has a major trauma, right, arginine helps because arginine has two issues, right? Arginine in the body is broken down by arginase, right? And that's why there is an acute deficiency. Arginine is not an essential amino acid. We actually make it in our body. But there is a relative deficiency of arginine. And that's why, and most important thing is, arginine is the main factor for development of collagen in the form of citrulline. Citrulline, it's a very long process. It goes to the liver, from the liver, it goes to, it goes into the blood. From there, it goes into the renal medulla, gets converted to citrulline, and citrulline is the main precursor for collagen. And we need that. At the same time, arginine is also very important, especially arginine in critically ill patients is actually used up. And it's by nitric oxide synthetase. And the reason is the nitrate species increase and they actually kill the bugs. And that's one of the reasons there is deficiency. The side effect in patients who are in septic shock is the macrophages have another enzyme called nitric oxide synthetase. It is not present in, it is not the same as arginase. It is the activated macrophages that actually produce it. And they produce nitric oxide. They convert it to nitric oxide. And we all know that nitric oxide is a vasodilator. And on one side, Dr. Ganshyam is trying to increase the blood pressure or perfusion pressure to increase minimum pressure so that there is adequate perfusion to the vital organs. And if you give arginine in this phase, then the blood pressure goes down. So the role of arginine is only in major trauma, upper GI cancers, elective surgery. How long to give? At least 4 to 5 days before. If the patient is an elective, is a major trauma patient, as soon as you can. Intravenously, it's not available. It's better to give it orally. That's about arginine. Now about omega-3 fatty acids. Basically, the fat which we consume is omega-6 fatty acids that's converted to arachidonic acid. It sits, we make about 1 to 2 or 3 or many billions of cells daily, right? That includes the macrophages, the neutrophils, the platelets. All of these are activated in presence of sepsis or presence of acute illness. Now, if it is an arachidonic acid, and remember all the cell walls are made up of lipids and carbohydrates and some parts of protein. The lipids here are the arachidonic acid, and this arachidonic acid goes into the cytoplasm, activates an enzyme called kappa, what is it? Nuclear factor kappa B. Nuclear factor kappa B is a very silent enzyme sitting in the cytoplasm. And this arachidonic acid goes and stimulates that. And directly it goes and stimulates the nucleus and it increases the secretion of, what does nucleus have? It has DNA. DNA sends messages in the form of messenger RNA to go to the ribosomes and make interleukin-1, interleukin-6, tumor necrosis factor alpha, right? It increases the pro-inflammation, right? Directly also arachidonic acid increases these. So if you give the patient omega-3 fatty acids, the daily amount of billions and billions of cells which are making, the acid there is eicosapentaenoic acid, the EPA, which is an omega-3 fatty acid, right? And that stops the nuclear factor kappa B activation. At the same time, it reduces the interleukin-1, 6 tumor necrosis factor activation or increase in their secretion, whilst increasing interleukin-14, right? That is an anti-inflammatory molecule. At the same time, reducing pro-inflammatory cytokines, increasing the anti-inflammatory cytokines, and more important, number 3, is it increases or produces a thing called resolvin. Resolvin, as the name, is an enzyme, is a molecule that resolves inflammation. Then there is one more, fourth one called protectin, because of omega-3 fatty acids. And this protects us from the excessive amount of cytokine storm syndrome and various other things, just like heat shock proteins do. So they are called as specialized resolving molecules. And that's why, so omega-3 fatty acids have very many functions. So you can actually use it. If the patient intravenously, if you start using it, it acts within 3 hours. Orally, it takes about 3 days, provided the patient has pancreatic lipase function. Now, coming to the controversial glutamine, if the patient has got burns, if the patient has got patient is on hemodialysis, directly give intravenous glutamine. If the patient is already on parenteral nutrition and hemodialysis, you can add glutamine. For patients who are not on parenteral nutrition or on parenteral nutrition, and the patient has an acute kidney injury, who's not on dialysis, or the patient has got liver dysfunction, right? These are the patients we should not be using glutamine, right? This is by the same authors who came up with the redoxis trial, right? And Paul Wishmar was one of them. They actually came up with these guidelines. If you can do the serum glutamine level, it actually is low. Now, in 2019, there was a study published in Critical Care Medicine, I think, where they took 20 critically ill patients and serially they took biopsies of their muscle. And they took 20 healthy individuals and daily they took biopsies of their individual. And about 59% of these intramuscularly, there was low skeletal amino acid pool. Now, what was surprising is 72% of these patients, 20 patients who were admitted to the ICU, 72 patients had low muscle glutamine level, right? So we already know this. So this study was published in 2014, I think, or 2015, soon after the redoxis trial, right? So we know that critically ill patients have low serum glutamine level. Most of the glutamine is present in the muscle. And there we have shown that, or these studies have shown that even the muscle has low glutamine. So yes, so if you want to start, you very have to closely monitor. But patient is AKI, not on dialysis, liver failure, do not use it. Multiple organ failures, Apache 2s of 2018, 19, 20, do not use it. Early onset, you can use it. Do not cross more than 20 to 30 grams in 24 hours of glutamine. I think I've given an overview of even the nutrients. Ghanshyam.
Yes, yeah, thank you so much. There's one more question, interesting question by Kanchana. Role of thiamine in sepsis.
Every patient should get it because we need thiamine, glucose metabolism. Glucose is the main source for many things, and glucose is the one that needs thiamine. In the absence of thiamine, patient is already acidotic, right? We are pushing the patient more towards metabolic acidosis, right? And that's the reason why we have to give the patient at least 100 to 200. I give 200 in my patients who are very acutely ill, at least for 3 days, right? At least for 3 days, and then gradually increase it to 100. As long as the patient is on IV, daily I give them, because there is nothing like thiamine toxicity. And thiamine is a water-soluble vitamin, right? It's B1. So many, in fact, it helps in cardiac function, it helps in brain function. So chronic thiamine deficiency gives the wet and the dry cardiac failure, psychosis, various other things. So it's very essential. Give it intravenously first 4 to 5 days and gradually convert it to oral. Ghanshyam.
So I have one question. Yeah. So if I can break down your entire talk, well, the gist seems that ultimately in critically ill patients, or I'll say my patients, need ATPs, and they have to come from food. Right now, is there any ways, right, where I can optimize this, or is it beyond our control? I know it's a very complex question, but at the end of the day, when I'm looking at my patients, how can we optimize their energy production?
If 2 + 2 is not 4 in this particular instance, because if the patient needs more ATPs, more energies, and the patient is acutely ill under your care, hey, just ramp up the caloric intake and see that patient improves. That doesn't happen, does it?
No.
The reason it doesn't happen is because of the various metabolic aspects, which I already said in the second part of my lecture. One of them is insulin resistance. The biggest thing is actually the mitochondrial dysfunction, right? So we are, any amount of food which you give the patient, any amount of nutrients you give, either intravenously or through the tube or orally, patient will not be assimilating them, right? Patient will not be metabolizing them, right? To the same extent as a person who is not critically ill. Does it mean that we should not feed our patients who are in the ICU? No. We should be mindful. Now, what happens in the first 2 days in the ebb phase, right? There is vasoconstriction. There is hypometabolism. Now, in this particular stage, if you go with all guns blazing, with 25, 30 kilocalories per kilogram body weight, you're actually causing the patient more damage, right? That is the reason why in Paul Vishmar's slide, go down to 10 to 15 kilocalories for at least 3 to 4 days, right? But after the ebb phase, that is after 48 hours, start the flow phase or the late phase of acute illness. There gradually you increase directly the proteins, because that's where proteins are broken down. You need to give them proteins, right? Intravenous proteins. It's available as amino acids. At the same time, 3 things are happening. Patient is breaking down his proteins, so we have to give the patient proteins. Patient has got insulin resistance. There is no way we can deal with that unless treat the patient's cause of intensive care admission. And if the patient has got a correctable, surgically correctable, then do that. Infective focus, drain it. That is the number 2. The third one is actually increasing the functions of the mitochondria, right? So give the patient carnitine, give the patient coenzyme Q, give the patient magnesium. The formula for ATP is ATP-Mg, right? You need to push whatever fats you are giving through the intravenous into the mitochondria. Give the patient carnitine, especially in patients who are seeing CKD. They have very severe carnitine deficiency. So we need to be mindful of that. We're not only giving the nutrients, but we have to think that are they getting digested? Are they giving the main benefits like providing ATP and water and carbon dioxide, right? So we need to look at all these things. The fourth important thing is the huge gut, the biggest source of sepsis in every patient who's in the ICU, be it cerebral malaria or be it due to respiratory COVID-19, right? The toxins, the exotoxins, the endotoxins, the entire bacteria themselves, including the fungi, can migrate because of the leaky guts, go and settle down in the lungs and cause acute lung injury, ARDS, and various things. So we need to maintain the integrity. We have to maintain the integrity. And the only way to maintain that is by feeding the patient minimally, 15 to 20 ml per hour. And that maintains the gut integrity. It will not, I repeat, it will not provide calories, but maintains the gut integrity. The patient needs more calories after day 3, day 4. You give the parental route. So just by giving calories will not help. You need to be mindful of all these things. And that's the reason why you need to be as much an expert in the nutrition metabolism as you are in the nuances of the various kinds of shock and sepsis.
Yeah. So one more question, though we are running out of time, but because the discussion is so interesting and such a learning experience, I would like to take this question. It's from Vijaya Agrawal. Well, what is the dose of fish oil that you would like to give in critically ill patients, and are there any contraindications?
Yeah, there are Let's start with contraindications. If the patient has got bleeding problems, because excessive amount of omega-3 fatty acids will cause platelet dysfunction. Normally, whenever there's an injury, the platelets are nice, spherical, they become spiky. It's called platelet release reaction. And that's how they form platelet plug. And also subsequently platelet breaks down and we get platelet-derived growth factors, which are so very important. It has angiogenic factor, it has epidermal growth factor, it has fibroblast growth factor. All of them come from platelets. So and omega-3 fatty acids in excessive amounts will cause dysfunction of these. So be mindful of that. Other thing, excessive amino, because it's an anti-inflammatory one, it actually reduces the cell-mediated immunity. Right. And we need the cell-mediated immunity in many, many things. And one of the commonest things is that is how we actually kill the Mycobacterium tuberculosis. I've just given one example, Mycobacterium tuberculosis. So it can be an immunosuppressive in excessive one. Now, how much to give? Right. We need to be very, very mindful. 0.35 to about 0.45 grams per kilogram per day. Right. If you're giving orally, it's about EPA, DHA together. It should be about 500 grams. If the patient is in severe sepsis, severe SIRS, you can go up to 1 gram, in other words. If you inherit a patient who's got significant atherosclerosis or has got acute coronary syndrome, superadded, or is got coexisting cardiovascular disease, then you need to go at least to 1.5 to 2 grams, right? These are the American Heart Association guidelines. And if the patient, there are very good studies, they are pro and for, but I would still recommend the patient, if the patient is at risk of developing ALI, then it's better to give the patient omega-3 fatty acids. So be mindful of the dose. At the same time, just by giving orally, patient may not be absorbing. If he has pancreatic dysfunction, give intravenous.
So there's one more question from Jayashri, right? Dose of arginine.
Not more than 5 grams. 5 to 10 grams is what? Basically, there have been studies to show that, especially in HIV, they go up to 15 grams. And there have been studies in patients who are undergoing elective upper GI cancer surgery. They give 5 grams per day for at least 5 days, right? So you give at least 1 to 2 grams, right? It's available. Right? There is one formula that is available as a sachet, which contains about 5 grams, right? Not more than 5 grams in patients who are not in severe sepsis. But major trauma patients, elective surgery patients, and upper GI cancer patients, yes, along with omega-3 fatty acids. Ghanshyam.
Thank you so much, sir. Thank you so much. I mean, it's been a fantastic learning experience for me as well. So many doubts cleared. We don't have any further queries. I'll hand over to Dr. Harsh or Ramesh from Pulse Nutrition if you are there.
Yeah, we are very much there. I think Dr. Harsh is there, sir, already. I think over to Dr. Harsh to please take over and then conclude the session also through that. Is Dr. Harsh available?
Yes.
Yes, sir.
Yes, I managed to.
Thanks a lot. Thanks a lot for coming.
I'm so sorry because of those delays.
Technical glitches.
And yes, I don't know, they were beyond me somehow, and I had to redo everything. Thank you, Dr. Ravinder, for such a enlightening talk, and all the efforts put in by Dr. Ganshyam to ensure that the message has gone home, because that's something which is very important. No, Dr. Farheen Ahmed, you cannot get the PPTs of Dr. Ravinder. I think he has not been telling you this, but then PPTs are their thoughts, which are very personal. They've shared, and I don't think Dr. Ravinder would like to share the PPTs.
No, I can send the written. I have a written thing about this. I can send you. I can give it to Ramesh or somebody, and you can give it to.
Okay. So he's lucky. You've been kind. But most of the presenters, they are positive about their PPTs, and they would not like to share. Just to conclude, I would like to thank you again on behalf of Pulse Pharmaceuticals. I'll just take a few minutes because we have been a company which has been in existence in the last 25 years. We are very much innovation-driven and a patient-centric company, and a huge focus on nanopharmaceuticals apart from medical nutrition. And now recently we are getting into stem cells. To be more specific, it's CAR-T that we are working on. And we have been collaborating with the Center for Cellular and Molecular Biology, where we have a setup of our own also. We have a dedicated lab. So hopefully we are coming out. It's a foray in a personalized medicine, but yes, we'll be coming out with that. We are very sure about it. I've already started talking to DCGI about it. And we have in medical nutrition an array of products which are available by the brand names of Canvel and Copwell and Gratchwell for various needs, diabetic care and critical care and cancer care, also the weight reduction. So these are the few words. I thank you so very much. And glitches, I'm sorry about it. They were beyond my control. So thank you, Dr. Reddy. Thank you, Dr. Ganshyam. for sharing your thoughts and views. And thank you so very much.